Metabolic bone diseases. They sit right at the intersection of medicine and orthopedics, and most students find them confusing. But honestly, the confusion isn't because the topic is hard. It's because no one ever shows you the underlying logic. Once you see that logic, everything else just falls into place. So that's exactly what we're going to do today. We'll start from calcium physiology, the foundation, and work our way through rickets, osteomalacia, scurvy, primary hyperparathyroidism, and renal osteodystrophy. And here's the promise. By the end of this, you'll be deriving the lab patterns yourself, not memorizing them. Before we get into any diseases, let's quickly build a mental model of what bone actually is, because everything else in this lecture depends on it. Think of bone as having two ingredients. The inorganic component, the mineral, is calcium and phosphate combined as hydroxyapatite. That's the hard stuff that gives bone its strength. And then there's the organic component, the osteoid, which is collagen and cells. Think of osteoid as the scaffolding on which the mineral gets deposited. Now within that scaffold, you have three types of cells. Osteoblasts are the builders. They lay down new bone matrix. Osteoclasts are the cutters. They break bone down. And osteocytes are essentially the maintenance crew. They sit embedded in the bone matrix and maintain it, but they're not doing the heavy lifting. There's one key detail about osteoblasts that you need to lock in right now, because it will come back again and again in this lecture. Osteoblasts are packed with an enzyme called alkaline phosphatase, or ALP. Whenever osteoblasts are active, whether they're building bone or rebuilding after breakdown, ALP spills into the blood. So a raised ALP in a bone disease context is your signal that bone turnover is happening. Keep that in the back of your mind. The last concept here is bone turnover itself. Bone isn't static. Osteoclasts are constantly breaking it down and osteoblasts are constantly rebuilding it throughout your entire life. When this balance is disturbed, disease follows. Too much breakdown, too much formation, or not enough of either. Each scenario produces a distinct pattern. And understanding what tips the balance is really the key to understanding these diseases. Now that we know what bone is made of, let's understand what controls the calcium inside it, because that's where the whole story of metabolic bone disease begins. 99% of your body's calcium is sitting in bone. What regulates the remaining 1% in the blood are three substances: parathyroid hormone, PTH, calcitonin, and vitamin D. Let's start with the simplest one. Calcitonin is secreted when calcium is high, hypercalcemia. Its job is to pull calcium back down to normal. Clinically, it's the least important of the three, so don't spend too much time on it. PTH is where the real action is. It's secreted when calcium falls, hypocalcemia, and its entire purpose is to bring serum calcium back up. It does this through three mechanisms, and each one is worth understanding properly. The first mechanism is in the kidney. PTH activates an enzyme called 1-alpha hydroxylase, which converts the inactive form of vitamin D into its active form. That active vitamin D then travels to the gut and pulls calcium into the bloodstream. So PTH is indirectly boosting gut absorption through vitamin D. The second mechanism is also in the kidney, but this one is direct. PTH tells the kidney to reabsorb calcium from the urine back into the blood. Now here's the catch. Every time calcium comes in, phosphate goes out. The kidney works on an exchange principle: calcium in, phosphate out. That's going to be critical when we look at the lab patterns later. The third mechanism is in bone. PTH mobilizes stored calcium from bone by stimulating bone resorption. And here's a classic MCQ trap. PTH doesn't directly talk to osteoclasts. Its receptors actually sit on osteoblasts. So PTH acts on osteoblasts, which then release a signaling molecule called rank ligand. Rank ligand then activates osteoclasts to break down bone and release calcium into the blood. This two-step relay is important. PTH receptors on osteoblasts. This has been directly asked in AIMS. And denosumab, which you'll come across clinically, works by blocking rank ligand, thereby suppressing osteoclastic activity and reducing pathological bone breakdown. Once serum calcium comes back to normal, negative feedback kicks in and PTH shuts off. That's the healthy system working as it should. Vitamin D itself is triggered by low calcium, low phosphate, and directly by PTH. Its primary role is to restore both calcium and phosphate through gut absorption. Before we move into individual diseases, there's one distinction you absolutely must be clear on: the difference between primary and secondary hyperparathyroidism. Because this single concept underpins every lab table you're going to see going forward. Let's start with secondary hyperparathyroidism, because it's the easier one to grasp. Here, the body is secreting excess PTH because it has a legitimate reason. Calcium is low, meaning there is true hypocalcemia. The parathyroid gland itself is perfectly normal. It's simply responding to a signal, doing exactly what it's supposed to do. And crucially, once calcium normalizes, the negative feedback loop kicks in and PTH drops back down. The system is intact, just working harder than usual. Primary hyperparathyroidism is a fundamentally different situation. Here, there is actual disease in the parathyroid gland itself, most commonly an adenoma. That diseased gland secretes PTH without any trigger. It doesn't need low calcium to start firing, and it doesn't respond to negative feedback even when calcium rises. So calcium keeps going up, phosphate keeps going down, and bones keep getting broken down, and nothing in the body can stop it. Let's compare them side by side to make this really clear. In secondary hyperparathyroidism, the underlying cause is hypocalcemia. Conditions like vitamin D deficiency or renal failure are the usual culprits. There is a reason for the PTH to be high. Negative feedback works, so PTH will eventually drop. Serum calcium starts low but can correct. Phosphate tends to be low because PTH is pushing it out, and ALP is elevated because bone turnover is happening. In primary hyperparathyroidism, the underlying cause is the adenoma itself. PTH is secreted autonomously, no trigger needed. Negative feedback is completely absent. So calcium is persistently high, phosphate is low, and ALP is elevated. One more principle to lock in before we go further. Whenever bone is broken down, osteoblasts immediately rush in to try to rebuild it. That osteoblast activity raises ALP, regardless of whether the underlying problem is causing too much or too little mineral. So high ALP simply tells you that bone turnover is active. It doesn't tell you the direction on its own. Keep that in mind as we go through each disease. Before we dive into each condition one by one, let me give you a master framework, a way to organize all the metabolic bone diseases together so nothing feels scattered. Every metabolic bone disease affects one of three components of bone: the mineral, the collagen, or the cells. When the mineral component is affected, meaning calcium and phosphate are disturbed, you get rickets, osteomalacia, and primary hyperparathyroidism. These will all have abnormal labs. When the collagen component is affected, you get two diseases: osteogenesis imperfecta, where the collagen is genetically abnormal to begin with, and scurvy, where collagen is structurally present but can't mature because of vitamin C deficiency. In both of these, the mineral labs, calcium, phosphate, ALP, are completely normal because the problem is in the framework, not the mineral itself. When the cells are the problem, specifically the osteoclasts, you get either Paget's disease, where osteoclasts are overactive, or osteopetrosis, where they're non-functional. And then finally, when the overall volume of bone is simply reduced without any underlying metabolic disturbance, that's osteoporosis. Labs are completely normal. It's a quantity problem, not a quality problem. Now, two things to hold clearly in your head going forward. First, scurvy and osteoporosis both have normal labs. Second, rickets, osteomalacia, and primary HPT will all have abnormal labs. That distinction is what your brain needs to anchor before we go into the details. Osteoporosis carries the heaviest exam weight of all of these, so it'll be covered separately in its own section. For now, let's go through the remaining conditions one by one. Alright, let's start with rickets and osteomalacia. And the first thing to understand is that these are actually the same disease, just appearing at different life stages. Rickets is the childhood form, occurring before skeletal maturity. Osteomalacia is the adult form, more common in young females, occurring after the skeleton has fully matured. Both conditions arise from vitamin D deficiency, which leads to hypocalcemia. Simply put, there isn't enough mineral available to deposit onto the osteoid framework. The most common cause is nutritional, meaning inadequate dietary intake. But it's worth knowing the other causes too, because they come up in questions. Malabsorption is one. Vitamin D is consumed, but never absorbed from the gut. Lack of sunlight is another significant cause, since sunlight is what activates vitamin D in the skin. Spending too much time indoors, or consistently using sunscreen above SPF 30, can meaningfully impair this. Then there's liver and kidney disease, because activating vitamin D is a two-step process that requires the liver first and the kidney second. Failure of either organ blocks the pathway, and certain drugs can also directly inhibit vitamin D action. Less commonly, dietary calcium deficiency or phosphate deficiency alone can cause rickets, but vitamin D deficiency is the one you should focus on. Now, two terms you need for exam questions. Osteoid maturation time is the time it takes for osteoid to become mineralized bone. In rickets and osteomalacia, mineral is deficient, so this time increases. Mineral apposition rate is the speed at which mineral actually deposits onto the osteoid. With less mineral available, this rate decreases. So osteoid maturation time goes up, mineral apposition rate goes down. That's a classic MCQ pair. Remember it together. Let's now derive the labs logically rather than just memorize them. Vitamin D deficiency causes hypocalcemia. Hypocalcemia triggers secondary hyperparathyroidism, so PTH rises. That elevated PTH tells the kidney to dump phosphate, so phosphate falls. And because there's ongoing bone breakdown and turnover, LP rises. Putting it together, calcium is low or low normal, PTH is high, phosphate is low, LP is high. Now let's get into the clinical features of rickets specifically. The core issue is that hypomineralized bone is soft, and soft bone deforms under mechanical load. Whatever forces act on it, it bends. The clinical changes in children follow a predictable sequence: skull first, then the chest, and then the long bones once the child starts weight bearing. Continuing with the clinical features, let's go through each region of the body in sequence. Starting with the skull. The earliest change is craniotabes. The skull softens to the point where pressing on it gives a ping-pong ball sensation. Along with this, you'll see frontal bossing, where the forehead becomes noticeably prominent, and delayed closure of the fontanelles. Moving down to the chest. Here you encounter the rickety rosary. These are swellings at the costochondral junctions, the points where the ribs meet the cartilage. They line up as a row of beads across the chest wall. Importantly, they are blunt and non-tender. I want you to hold that detail, because when we get to scurvy, there's a very similar sounding finding. The scorbutic rosary, but in scurvy those swellings are sharp and tender because they're caused by bleeding, not by bony expansion. That contrast is a classic comparison question. Also in the chest, pigeon chest, or pectus carinatum, where the sternum is pushed forward by repeated respiratory effort against soft ribs. And Harrison's sulcus, the diaphragm attaches on the lower ribs, and with every breath inward it pulls those ribs in. Since the ribs are soft, this repeated pull creates a horizontal groove just above the costal margin. Now the long bones. And here's an important timing point for MCQs. Long bone deformities only appear after the child begins weight bearing. An infant who hasn't started walking yet won't show any bowing. This is worth remembering. At this point, Let me quickly run through the anatomical terminology for joint deformities, because this comes up in both rickets and upper limb trauma questions. Coxa refers to the hip, genu to the knee, and cubitus to the elbow. To figure out whether a deformity is varus or valgus, look at the joint proximal to the deformity and ask, does the distal segment point toward the midline? That's varus. Or away from the midline? That's valgus. So genu varum is bow legs, and genu valgum is knock knees. Wind-swept deformity is when one side is varus and the other is valgus. Coxa vara means the neck shaft angle is less than 125 degrees, and coxa valga means it's above 130 degrees, the normal range being 125 to 130 degrees. A few MCQ associations to commit to memory here. The most common cause of wind-swept deformity in children is rickets. In adults, it's rheumatoid arthritis. The most common cause of bilateral genu varum in children is rickets. If rickets isn't listed in the options, choose idiopathic. In adults, it's osteoarthritis over rheumatoid. And the most common cause of bilateral genu valgum in children is idiopathic, followed by rickets. In adults, it's rheumatoid over osteoarthritis. Now let's talk about the X-ray findings in rickets. And to understand them properly, we need to briefly revisit the growth plate. The growth plate has layers: germinal, then proliferative, then hypertrophic, then calcification, then ossification. Normally, the hypertrophic zone progresses smoothly into the calcification zone. But in rickets, there's no mineral available, so the hypertrophic layer simply cannot progress. Instead, it just keeps expanding. Since the growth plate sits at the ends of long bones, this enlarged, uncalcified hypertrophic zone creates visible swellings at the wrist, elbow, knee, and ankle. That's your explanation for the swollen joints in rickets. On X-ray at the metaphysis, there are 4 characteristic findings to know. Cupping, where the metaphyseal cup shape is exaggerated. Splaying, where the metaphysis widens outward. Fraying, where the edges look irregular and fuzzy. And widening of the growth plate itself, representing that expanded hypertrophic layer. These 4 together, cupping, splaying, fraying, widening, are the radiological fingerprint of active rickets. Now what happens when you treat rickets? You give vitamin D, calcium absorption resumes, and mineral floods into the hypertrophic zone. Calcification occurs, and osteoclasts can now resorb the abnormal swelling. Because osteoclasts can only act on properly mineralized bone, not on osteoid or improperly ossified tissue. That's exactly why most of the deformities in rickets are reversible with treatment. The radiological sign of healing is a thick, dense band of calcification at the metaphysis. This is called the white line of Frankel. It's the best method to assess healing in rickets. It also appears in other conditions: scurvy, healing congenital syphilis, plumism, and leukemia, so it's not exclusive to rickets, but its appearance here marks recovery. Finally, treatment strategy depends on the child's age. In a young child around 2 to 3 years old, you give vitamin D plus splints. At this age, bone has excellent remodeling potential, so deformities will self-correct as the child grows. No surgery needed. But if the child is close to or past skeletal maturity with a residual deformity that isn't correcting, you perform a corrective osteotomy. Crucially, though, you must confirm the bone has fully healed before operating. And the way you do that is by checking serum ALP. If ALP has normalized, it means the bone physiology is restored and surgery is safe to proceed. Before we move on, let's quickly cover the vitamin D dosing for rickets, because it does come up in exams. The STOS regimen is a single large dose, 3 to 6 lakh international units, given deep intramuscularly or orally. Alternatively, you can give a daily dose of 2,000 to 5,000 IU for 2 to 3 months, or a weekly dose of 50,000 to 60,000 IU once a week for 2 to 3 months. And this weekly regimen actually has the best compliance among the 3. Now, osteomalacia, the adult counterpart of rickets. The same underlying mechanism applies, but the presentation shifts. Patients come in with polyarthralgia, bone pains, and proximal myopathy, all stemming from calcium deficiency. The orthopedic finding that really defines osteomalacia in adults is the pseudofracture. These go by 3 names, and you should know all of them: milkman's fractures, Looser's zones, or simply pseudofractures. The mechanism is interesting. The bone is so soft that the pulsation of arteries running alongside it causes repeated microstress injuries. These injuries try to heal, but because mineral is still deficient, the callus that forms stays as unmineralized cartilage rather than proper bone. On X-ray, they appear as transverse bands of rarefaction, lucent areas perpendicular to the long axis of the bone. The most common site is the medial side of the femoral neck, though they can also occur at the clavicle, ribs, scapula, and pubic ramus. One important note: pseudofractures are not pathognomonic of osteomalacia alone. They can appear in other conditions too. The pelvis is also affected in osteomalacia because it softens under the weight of the trunk above it. This produces a few distinct pelvic shapes. The triradiate or trifoil pelvis is one. The pelvis bends inward from 3 directions, resembling a 3-leaf clover. Protrusio acetabuli occurs when the femoral head pushes into the softened acetabulum. And champagne glass pelvis can also be seen, though it's more classically associated with achondroplasia. Be aware it's occasionally asked in MCQs in this context too. One more entity to be aware of: oncogenic osteomalacia, also called tumor-induced osteomalacia. Certain tumors can produce substances that cause osteomalacia as a paraneoplastic effect. It's a less common but well-known cause. Treatment of osteomalacia is the same vitamin D regimen we just discussed for rickets. Let's move to scurvy now, and this is where the framework shifts completely. Scurvy is vitamin C deficiency, and unlike rickets, it has nothing to do with minerals. To understand why it affects bone, you need to know what vitamin C actually does at the biochemical level. Vitamin C is required to hydroxylate 2 amino acids, proline and lysine, converting them into hydroxyproline and hydroxylysine. This hydroxylation is what allows collagen chains to cross-link and mature. Without vitamin C, procollagen cannot become mature collagen. What you're left with is weak, fragile collagen throughout the body. Since collagen is found everywhere, in bone, blood vessels, skin, and gums, scurvy affects all of these. In orthopedics, we focus on the bone. And here's the key distinction: the mineral component is completely unaffected in scurvy. Calcium, phosphate, and ALP are all normal. Remember that. It separates scurvy cleanly from everything else we've discussed. Now the clinical features. The most prominent changes involve the endothelium and gums, bleeding gums, subperiosteal hemorrhages, and bleeding at the costochondral junctions. At those costochondral junctions, you get the scorbutic rosary. These swellings are caused by bleeding, not by bony expansion, which is why they're tender and sharp. Contrast this with the rickety rosary of rickets, which is blunt and non-tender. That's a comparison you should be ready for in any exam. Another hallmark is pseudoparalysis. Subperiosteal hemorrhages are extremely painful, and the child simply refuses to move the affected limb. Parents think the child is paralyzed, but it's not true paralysis. It's pseudoparalysis from pain. This is also seen in osteomyelitis and septic arthritis, so keep those in the differential. Now for the X-ray findings, organized by region. In the diaphysis, the bone has a ground glass or hazy appearance with a pencil-thin cortex. It looks washed out because the structure is weakened. At the metaphysis, you'll see the white line of Frankel as a dense band, the same healing marker we saw in rickets, and just below it, a lucent area called the scorbutic zone or Trümmerfeld zone. At the edges of the metaphysis, you'll see pelican spurs, small bony projections sticking out at the sides. At the epiphysis, the most characteristic finding is the Wimberger ring sign. a sclerotic rim that forms around the epiphysis, making it look like a ring. This is the finding that clinches the diagnosis of scurvy. If you see Wimberger ring sign in an MCQ, your answer is scurvy. Treatment is simple: vitamin C supplementation. One last point before we move on: Barlow's disease. When a patient has both vitamin C and vitamin D deficiency simultaneously, the features of rickets and scurvy overlap and mix. That combined clinical picture is called Barlow's disease. Don't confuse this with Barton's fracture. That's a distal radius intra-articular fracture and belongs to upper limb trauma, a completely different topic. Now let's get into primary hyperparathyroidism. And we already have the foundation for this from the physiology section, so let's build on it. The most common cause is a parathyroid adenoma. The diseased gland secretes PTH autonomously, without any trigger, and completely ignores the normal negative feedback mechanism. PTH just keeps firing. Once you know the physiology, the consequences are predictable. Excessive vitamin D activation means calcium is absorbed in excess from the gut. Excessive renal calcium reabsorption means phosphate is constantly being excreted. And with ongoing bone breakdown, both calcium and ELP continue to climb. So the lab picture is calcium high, PTH high, phosphate low, ELP high. The systemic effects of hypercalcemia are summarized with the mnemonic: bones, stones, groans, and psychiatric overtones. Bones, bone pain from the relentless destruction. Stones, renal stones from the excess calcium spilling into the urine. Groans, abdominal pain from gastrointestinal motility disturbances. And psychiatric overtones, depression, fatigue, and anxiety, because calcium disrupts neurotransmitter signaling. Now for the bone changes specific to primary hyperparathyroidism. And this is what's most relevant for orthopedic exams. Salt and pepper skull, also called pepper pot skull, scattered tiny lucencies throughout the skull from ongoing bone resorption. On X-ray, it literally looks like someone has sprinkled salt and pepper across the image. Resorption of the lamina dura. The lamina dura is the dense layer of bone that surrounds the roots of teeth. When calcium is resorbed from here, the teeth lose their anchoring and become loose. Subperiosteal phalangeal resorption. This is where bone is resorbed beneath the periosteum in the phalanges of the fingers, specifically on the radial side of the middle phalanges. This X-ray finding is pathognomonic of primary hyperparathyroidism. If you see subperiosteal bone resorption on the radial side of the phalanges in an MCQ, the answer is primary HPT. And finally, the brown tumor, also known as osteitis fibrosis cystica, or von Recklinghausen's disease of bone. Excessive bone resorption creates cavities. Blood collects in these cavities. Hemoglobin degrades to hemosiderin, which is brown, and that gives the cavity its characteristic color. Despite the name, this is not a true tumor. It's a cavity filled with brown hemosiderin-stained fluid. That's a common MCQ trap. Don't let the word tumor mislead you. Treatment is surgical excision of the adenoma. The last major condition in this lecture is renal osteodystrophy, and this is probably the most MCQ-heavy topic in the entire module. So let's go through it carefully. Renal osteodystrophy is the bone disease that develops in chronic renal failure. To understand it, you need to know what failing kidneys do simultaneously, and there are three things. First, vitamin D activation fails. The enzyme 1-alpha hydroxylase is kidney-based, so when the kidney fails, that enzyme stops working. Active vitamin D drops, and calcium absorption from the gut falls with it. Second, calcium can no longer be reabsorbed from the urine, so serum calcium falls further. Third, phosphate cannot be excreted because the kidneys are the primary route for phosphate clearance. So phosphate builds up in the blood, hyperphosphatemia. The net result is hypocalcemia combined with hyperphosphatemia. And hypocalcemia, as we've now seen multiple times, triggers secondary hyperparathyroidism, PTH rises. Now PTH tries to do its job through the three usual mechanisms. Activating vitamin D via the kidney fails because the kidney is gone. Reabsorbing calcium via the kidney also fails. The only pathway still available is bone breakdown. So PTH relentlessly breaks bone down and releases calcium. But then the failed kidney can't hold on to that calcium. It spills straight out into the urine. Serum calcium never normalizes. PTH keeps breaking down more bone in a futile cycle, progressively destroying the skeleton. That's the vicious loop of renal osteodystrophy, and the name itself captures it well. The lab picture: calcium is low, PTH is high, phosphate is high, and ELP is high. Now here's the feature that separates renal osteodystrophy from every other form of secondary hyperparathyroidism. Phosphate is high. In all other secondary HPT states, phosphate is low because PTH is dumping it out through functional kidneys. In renal osteodystrophy, those kidneys can't excrete anything, so phosphate accumulates. High phosphate in a bone disease MCQ. Think renal osteodystrophy. That's the distinguishing feature. The X-ray finding is rugged Jersey spine. The vertebral end plates become sclerotic while the central part of the vertebral body stays relatively loosened. This alternating pattern of dense and pale horizontal stripes looks exactly like the stripes on a rugby jersey. Rugged Jersey spine is a direct MCQ answer for renal osteodystrophy. Fix that association in your memory. And that brings us to the end of part 1. Let's just take a moment to pull everything together. Metabolic bone diseases stop being intimidating the moment you understand the physiology behind the labs. Hypocalcemia triggers PTH. PTH acts on osteoblasts via rank ligand to break bone down. ELP rises with any bone turnover. When kidneys fail, both vitamin D activation and phosphate control go out the window, and that gives you the unique lab picture of renal osteodystrophy, with high phosphate setting it apart from everything else. Rickets deformities are reversible with treatment. Healing shows up as the white line of Frankel, and you never operate until ALP normalizes. Scurvy is a collagen problem. Minerals are normal, the Wimberger ring sign is on X-ray, and the scorbutic rosary is tender and sharp. None of this is something to memorize in isolation. It's all something you can derive from first principles. If this lecture helped you, hit like, subscribe, and drop your questions in the comments. Part 2 covers osteoporosis, Paget's disease, osteopetrosis, and osteogenesis imperfecta, and we'll tackle those with the same approach. Stay curious,